Well, thank you very much for inviting me to speak. That's an extremely hard act to follow, so bear with me. But I'm going to talk about red cell alloantibodies. All right, so I have no relevant disclosures other than that I'm a member of a nonprofit company that we formed with the goal of helping to facilitate red cell antibody exchange in the United States, which I will talk about at the end of this 20 minutes. So we have 3 objectives for this brief 20-minute talk. We're just going to start by talking about red cell alloimmunization induction and sequelae. So as everyone in this audience knows, we do antibody screens in the blood bank just to look for existing antibodies, and we select units lacking cognate antigens for transfusion. So typically a unit selected is going to be ABO and RH compatible and not further matched. But red cell alloimmunization occurs after exposure to non-self antigens through either transfusion, pregnancy, or occasionally IV drug use. And as this nice picture drawn by Dr. Wester shows, there are just many red cell antigens. They have different structures, they have different functions. Some are multi-membrane pass, some are single membrane pass, some are present on red cells, some are present on many other tissues in the body. But antibodies can increase the risk of immediate or delayed hemolytic transfusion reactions. They can also lead to lengthy delays in providing compatible blood for highly alloimmunized patients, and then they can be significant in pregnancy as well. So these are data from our US-wide REDS3 study, which was completed a few years ago, just showing that about 3 to 5% of the general transfused patient population has antibodies. These antibodies increase in likelihood with increasing age of the patient. And we know that antibody prevalence is underestimated given the phenomenon of evanescence. So more than 60, maybe 70%, maybe more of red cell antibodies evanesce or fall below the level of detection in the blood bank. So for example, a patient may be transfused in Canada. They may develop an anti-JKB antibody. They may come to my institution in New Haven, Connecticut. We can't detect that antibody. We don't know that you had detected that antibody. We expose them to antigen-positive red cells, and they have an anamnestic response and can have a delayed hemolytic transfusion reaction. This talk is somewhat centered towards people with sickle cell disease, but of course alloimmunization can occur in any patient population. It's possible that patients with sickle cell disease have higher rates of evanescence than patients without sickle cell disease, but it's also possible that we simply screen these patients more frequently. But there are 2 publications over the past decade looking at evanescence rates in people with sickle cell disease. First manuscript reports about a 64% evanescence rate. And the second manuscript by Williams and et al. Reports about an 81% evanescence rate. So certainly very common that these antibodies become undetectable. And if you don't know a patient has an antibody, obviously you're not going to antigen match for the transfusion, and the patient's going to be more at risk of a delayed hemolytic transfusion reaction, which of course can happen to any patient of any diagnosis, alloimmunized for any reason. However, people with sickle cell disease are more likely not just to have the DHTR, but also to undergo bystander hemolysis, also called hyperhemolysis, which we don't fully understand. But basically, it just means these patients are destroying their own red cells in addition to the transfused red cells. And the incidence of DHTRs with bystander hemolysis may be as high as 4%, with mortality above 10%. And these DHTRs with bystander hemolysis in people with sickle cell disease in particular are underappreciated, again, and potentially fatal. Many are antibody positive, meaning an anamnestic, response occurs, complement is fixed, red cells are hemolyzed. However, about a third of DHTRs with bystander hemolysis have no new detectable antibody present. That being said, many of these patients have historic antibodies. We think these reactions are at least in part free heme and complement mediated, but we don't really understand them. So this pie chart shows sort of what I was taught, in training, that DHTRs are pretty uncommon, that febrile non-hemolytic transfusion reactions and allergic reactions are by far the most common transfusion reactions. However, in patients with sickle cell disease, this is what the likelihood of DHTRs actually looks like. They are much more common than any other transfusion reaction combined. They may not be reported, depending on what country you live in. They may not be required to be reported if they're not fatal. All right, so very briefly moving on to recipient variables impacting alloimmunization, which is what I've spent a large time of my research career studying. So this slide shows many factors. We don't have time to go over them all, but you can imagine there are factors on the blood donor side. There are potentially red cell unit factors like leukoreduction, irradiation, storage duration. There are potential antigen factors. So is a donor unit homozygous, heterozygous for a particular antigen? What's the copy number? And then recipient factors such as inflammation, such as the prior speaker was just speaking of. Is there a danger signal present at the time the recipient sees the antigen? I'm just going back to our REDS3 data set. We found that females were more likely to have alloantibodies than males, particularly around the childbearing years. This has been reported by others as well. And we found that disease status impacts red cell alloimmunization. We found that in the RED study. This is just a slide that I put together, a composite slide, of many prior publications. But sickle cell disease patients have the highest prevalence rates of red cell alloimmunization, followed by patients with myelodysplastic syndrome, Thal major, and other autoimmune diseases such as lupus, rheumatoid arthritis, etc. So why do so many patients with sickle cell disease form antibodies? Certainly, these patients have a higher transfusion burden than many other patients. And that transfusion burden may be seen at the time of illness, and it may be unavoidable. So a patient may have acute chest syndrome, and transfusion is indicated to treat acute chest syndrome. We know from work that Ross Faisano has done that transfusion at the time of acute chest syndrome is associated with significantly higher likelihood of forming antibodies. Baseline inflammation can also be associated with free heme, reticulocytosis. Patients with sickle cell disease have thrombocytosis at baseline, have activated platelets at baseline, and then also some of the patients have leukocytosis. Work by Stella Chow, Connie Westhoff, and many others has looked at Rh genetic diversity in individuals with sickle cell disease. We know that this is a risk factor for alloimmunization. Not just on the recipient side, but also Rh genetic diversity on the donor side when you attempt to closely match or phenotypically match with recipients. But there's probably a missing piece of this puzzle that we don't fully understand yet to account for the 40, nearly 50% alloimmunization prevalence rate in people with sickle cell disease. And I guess unspoken is why do 50% of people with sickle cell disease never form an antibody? So we have some patients at my hospital that have received 500 or more red cell transfusions without forming an antibody. So I think that patient population is understudied. This is a letter submitted by Dr. Boating sometime earlier this year that I think points out a really important concept that we may not think about often enough. But basically her letter shows that we do not identify all antibodies in individuals with sickle cell disease because our screening cells that we're using are largely from Caucasian donors. So in this paper, she looked at the specificity of antibodies in individuals from Ghana. And when she used screening cells from Africans that were similar to the recipients in her study, she identified a third more antibodies. So I think there are antibodies that go undiscovered just given our screening cells and our screening panels. So certainly in the mouse world, as well as the human world, inflammation has been associated with red cell alloimmunization, whether that inflammation is in mice, a double-stranded RNA that mimics viral-like inflammation, whether in humans, it's inflammatory bowel disease, acute chest syndrome with sickle cell disease, chronic inflammatory autoimmune disorders or other types of infections. All right, and then the last 5 or 10 minutes just to talk about how can we try to prevent dangers of evanesced antibodies. So we know antibodies exist. We know antibodies evanesce. We know these antibodies can be clinically significant in transfusion and pregnancy, more so for some patient populations than others. But how can we prevent their dangers? So I don't have the answers. Number one, we could reduce the risk of aluminization to begin with. So this is obviously ideal. So for people with sickle cell disease, we prophylactically match. For CE and CAL, many hospitals, at least in the United States, do this on a phenotypic level, although some studies are looking at this on a genotypic level. Judicious use of red cell transfusions is potentially the most important thing any clinician can do. So don't transfuse if the individual doesn't need a transfusion. So if a patient's hemoglobin is 6 and they're about to be discharged from the hospital and their baseline is 7 and they have no hypoxia, they don't have acute chest syndrome, don't transfuse them. And then ideally, we would be able to identify a priori which individuals are more likely to make antibodies. So we would call those responders from non-responders really upfront, but we do not yet have an assay to identify those patients. Number 2, reduce the risk of missing the detection of transient antibodies. So if we have a patient that's in the hospital, we transfuse them, they go home. At least in the United States, there's no rule that they must have a repeat antibody screen after transfusion. They only have to have an antibody screen prior to the next transfusion. We know that most antibodies are formed within 12 to 16 weeks of a given transfusion, although some are formed very quickly and may evanesce before they're even identified. So having a plan for a follow-up antibody screen could be a good idea, although it does involve resources and it will not pick up all antibodies. In the United States, patients seek care at many different hospitals through different healthcare systems that are not connected via any kind of electronic medical record system. So optimally, the patient would know their transfusion history, would know their antibody history, and optimally, there would be better inter-institutional blood bank communication. And then likewise, to reduce the risk of re-exposure to an evanesced antibody really requires better communication than we currently have, at least in the United States. So this leads me to something that I and many other people are currently working on, is a United States-wide red cell antibody exchange or registry. And we are in the early stages of this. But there are many different publications from the transfusion medicine community, hematology communities in the United States and in the world that acknowledge that an antibody registry would improve transfusion safety. There have been a couple of localized antibody registries in the United States. There's been one successful antibody registry outside the United States that's been in existence for about 10 years now, called the TRIX registry in the Netherlands. Has been shown to, or is predicted to decrease the likelihood of delayed hemolytic transfusion reactions by about 50%. So as we begin to plan for a US-wide antibody registry, we sent out a survey to AABB members who are physicians in the United States, and we got 66 responses. There was near universal support of at least the idea of an antibody registry. So 64 respondents were interested and 2 were opposed. The 2 that were opposed for patient privacy reasons. So again, myself and many others are trying to basically become intermediaries to help hospital blood bank information systems exchange antibody information in the United States. So we want to build an alloantibody health information exchange. So in the United States, there are about 6 big blood bank information system vendors. Most hospitals in the United States have one of these vendors. At present, none of these vendors communicates with each other. So although some health information in the United States is currently shared on the, Epic and physician note level, there is no blood bank data that is currently shared from blood bank to blood bank. So ideally, we would like to have different hospitals with different blood bank information system vendors be able to exchange information through a cloud registry. And we're doing this because we would like to save lives. We know there are many evanescent antibodies. We know we miss antibodies all the time. We see patients at my hospital with sickle cell disease that have a negative antibody screen. Maybe they have a hemolytic transfusion reaction, and then we find out, oh yes, this patient was actually seen at 5 different hospitals, all across the United States. And some of those hospitals may have identified other antibodies, and other hospitals may have had negative antibody screen. So currently, the way we do this, at least in the United States, is we ask the patient, where have you been? And we start getting on the phone and calling different blood banks. As you can imagine, that's not very efficient. And some of the data we receive is not accurate either over the phone. So again, like I mentioned, there's a registry called the TRIX registry. It's been in existence in the Netherlands for over a decade. It has a similar structure, not exactly the same, but a similar structure to what we're proposing in the United States, and has been highly successful. So again, in the United States, there are about 6 main blood bank information system vendors. These are just data from our survey, so these are not exactly representative of the entire United States, but our goal is to have these 6 vendors agree to participate in an antibody exchange, and we think we'll have extremely good coverage of hospitals in the United States if we can get these vendors to agree. So over the past year or two, we've had discussions with many different organizations, patient support groups, lawyers, ethicists, advocates, just to discuss this idea to see how we can move forward. So the American Society for Clinical Pathology, ASCP, was instrumental in developing a working group to try to move forward safer transfusion. And this is a group that is composed of volunteers, some on the blood donor side, some on the hospital side. And we've been meeting 3 or 4 times a year just to identify and remove barriers, to figure out which partners we need to engage to move this project forward. And then in 2021, the ACBTSA, which is the Advisory Committee on Blood and Tissue Safety and Availability, had a report to United States Congress on the adequacy of the blood supply. In that, we identified the lack of a national antibody registry as a significant risk to patient safety. And so a number of individuals involved in that report are part of our efforts to move a registry forward. One thing that we've identified as an issue in moving a registry forward is that there is no standardization of antibody name verbiage in these blood bank information system vendors in the United States. So for example, my hospital might call something we might have the letter little e with a line over it, and another hospital might put little L-I-T-T-L-E-E. My hospital might call something a panagglutinin, and another hospital might call something a warm auto. So we need standardization of all hospitals across the United States to be able to have kind of maximal, efficacy of antibody registry. So this is something that we are working on. We're proposing to use ISBT antibody names in addition to probably 10 other names of things that hospitals currently use, although again, there's variation from hospital to hospital. We have one blood bank vendor, Soft Computer, that has verbally and written committed to participate in our registry. And they're actively trying to update their software to be able to exchange data through the registry. In the United States, blood bank software is FDA cleared, so this will need to go through the FDA for approval. We do have participants on the FDA side who are interested in seeing this be successful to improve patient safety. So basically, we have interest and support on the part of the FDA, interest by the NIH, interest by the CDC, and interest by many other kind of organizations. So next steps, we need input and support from other blood bank information system vendors. We're meeting with 2 different vendors in the next week. I think some of them just want to see what happens when the first vendor goes to the FDA to try to get approval of their software to exchange data through a kind of cloud intermediary. This will not be expensive to support, but it will not be free. And so we've been in discussions with the government and other entities to try to get support for a registry, really to be able to sustain the registry beyond the life expectancy of those of us who are currently involved in trying to push this process forward. All right, so I think my time is up. I will stop there, stop sharing so I can see you guys. I'll take any questions.
Very much, Jeannie. That was really interesting. The talk is open for questions.
Actually, a registry is a terrific idea. I guess I got a question for Dana. Do we have a registry in Canada? Okay, thank you. The other thing is that obviously the evanescence problem is one of the major issues. You can retrofit it with a registry. Is there much interest in trying to alter the sensitivity of the antibody screening? I think it's been pretty static for several generations.
I first came into the lab, I'm a clinician by training. When I first came into the lab, that's something I was quite interested in. You can see things by flow cytometry, by ELISA that you can't see by our blood bank assays. So I initially was kind of gung-ho to try to increase the sensitivity, but then I realized that we already pick up an awful lot of things in the blood bank with our less sensitive assays that are not clinically significant. And I think I've been convinced that we do pick up most of what we need to pick up, with the exception of, I do think it would be a good idea to have a screening panel. For example, if you have a patient with sickle cell disease, their antibody screen is negative, they're having a DHTR, do they have an antibody, or are you just not identifying the antibody because you're not using the right screening cells? So I think the work that I described earlier by Dr. Boating is actually quite important for many parts of the world. And really, you need screening cells that are representative of the donors that you're picking for the patients in your part of the world.
It's Ed Conway. It's really interesting that you talk about lack of donor, really personalized medicine. It's personalized donor cells for blood screening. It's interesting that transfusion medicine is generally seen as way ahead in terms of personalized medicine, and yet we forgot that donor red cells are different from different parts of the world. Just a comment. Prior to the pandemic, I spent a fair bit of time in Uganda, and although I'm not directly involved, the sickle cell clinic there is spectacularly huge, and to have databases even locally would be extraordinarily helpful for screening purposes and for medical care.
Yeah, some hospitals, as you know, don't even do screening before transfusion, depending on where in the world you are. Some just do a cross match. So I think there's variable degrees of improvement that we can do, but I think all of us, no matter where we work, could have improvements in our records. And in my opinion, at least in the U.S., having an antibody registry is extremely low-hanging fruit, and is pretty surprising that we don't do that when we think about how much money we've invested in things like decreasing bacterial transmission in platelet transfusions. That has been extremely expensive and doesn't impact nearly as many patients as antibodies do.
Good master's PhD program.
That was really great. We're going to move on now to